another 15 minutes or so, I am going to talk about role of second generation BTK inhibitors in management of CLL, more so for the acalabrutinib. So all of us are aware that acalabrutinib is a more potent and selective BTK inhibitors. What makes it more selective and potent inhibitor is that it has butyronamide reactive component in its structure, which binds to CYS481 component of BTK receptor. The other very important thing about this drug is that it doesn't have much action on other receptors like EGFR or interleukin mediated T cell kinases. So thereby the other unwanted pathways are not being stimulated by this drug. It specifically more precisely acts on BTK inhibitor receptors, thereby makes it as more potent and effective. Acalabrutinib is approved in both treatment naive and relapsed CLL patients. We'll just go through the trial, which is Elevate trial, which was the major trial through which it was approved in treatment naive patient. The patients who enrolled in this trial were, most of the patients were of more than 65 years, and patients who had fragile, like for example, if you see that the cumulative illness rating score was more than 6. People who had less than 65 years, most of them had some coexisting morbidity. So that made this trial more for elderly and frail patients. Stratification wise, it had patients who had poor risk factors like deletion 17p and unmutated immunoglobulin heavy chain status also. This study had about 535 patients. It had 3 arms. The control arm was obinutuzumab in combination with chlorambucil. It was compared with acalabrutinib with obinutuzumab. Here, these drugs were given for 6 cycles, followed by acalabrutinib single agent. The third arm was single agent acalabrutinib. The primary endpoint was the progression-free survival comparison between the obinutuzumab and chlorambucil arm with that of acalabrutinib and obinutuzumab arm. The secondary endpoint, progression-free survival comparison between single agent acalabrutinib and control arm. Of course, the overall response rate was also assessed. A time to next treatment and overall survival and safety data were seen. People who had progression on the control arm were allowed to cross over to the acalabrutinib arm. The patient baseline character, all 3 groups was equally matched. As I was telling before, about 80% of the patients were, most of them were more than 65 years. It had around 10% of high-risk feature patient who had 17p deletion. About 60% of the patients in all 3 groups had unmutated immunoglobulin heavy chain status. There are about 10% of patients who carried T53 mutation. So independent review committee assessed progression-free survival after follow-up of 28.3 months did show that acalabrutinib combination arm had a PFS of about 93% and about 87% PFS in a single agent. The other control arm had only about 47%, thereby showing that the acalabrutinib did made a significant changes to progression-free survival. Hazard ratio was about 0.1 and 0.2 respectively, which was quite significant. The benefit was seen across the groups, whether the age was more than 65 or less than 65, irrespective of the sex, stage, and performance status. Very importantly, people who considered to have adverse prognostic or high risk factors like deletion 17p, more than 10 centimeter bulky disease, immunoglobulin unmutated status, people who carried complex karyotype, all these group benefited through acalabrutinib compared to that of the control arm, which was very important thing out of this study. Assessment of response rate, the acalabrutinib combination arm in comparison to that of the control arm, it was 93.9% against 78%, which was significant. Acalabrutinib single agent arm did had an overall response rate of about 85%. Overall survival, if you see the acalabrutinib arm either as a single agent or in combination with obinutuzumab, did have around 95% of the overall survival rate at 28.3 month follow-up. The control arm did also have about 90%. The 90% was because about the around 40% of the patients who were allowed to cross over from the control arm to the acalabrutinib. So it was too early to call for a difference in overall survival. So the results, though median overall survival is not yet reached, the estimated 30-month overall survival is that combination of acalabrutinib did show 95% at 30-month overall survival, single agent about 94%, The control arm about 90%. Remember, I told you that there was a crossover allowed in this study. 3% in acalabrutinib combination arm and 6% in single agent acalabrutinib arm were changed to next line of therapy compared to that of 31% in the control arm, which was bigger number. 25% of the patient in control arm were allowed to cross over to single agent acalabrutinib arm. The overall response rate was in combined acalabrutinib arm was about 94%. In control arm, it was 79%, which was statistically significant difference. The single agent acalabrutinib had overall response rate of about 85%. CR rates were very high in acalabrutinib obinutuzumab combination arm, which was about 13%. So most common adverse events, the important thing were headache, diarrhea, neutropenia. Other very, very important side effect was nausea. So one of the things the patient did have a high neutropenia incidence. Somehow it was seen more with the obinutuzumab arms compared to that of the acalabrutinib arm. But very, very important thing we must keep in mind that in acalabrutinib arm is that these patients are more prone for secondary infections. We must watch for it. These people are elderly, so whatever the infections are may be treatable until unless if you don't recognize them early, it can be fatal. Other very interesting clinical adverse effects in this drug were atrial fibrillation, hypertension, major bleeding was seen in about 2% of the patients. As I was telling, there were high rate of infection and there were also incidences of second primary malignancies. So these are some of the adverse effects which we need to be carefully watch when we start the patient on acalabrutinib. Basically, because most CLL patients are elderly, these side effects are can be very fatal if you don't recognize them early. So when you start the patient on this drug, this particular side effects, though they are less in number, need to be watched, especially the infections. Regarding dose reduction and discontinuation, acalabrutinib combination arm had about 7% of the patient dose reduction and about 11% of them had discontinuation due to side effects. About 4% in monotherapy did have dose reduction and about 10% discontinued the drug. So in conclusion, the combination or as a single agent acalabrutinib did show a significant progression-free survival compared to that of the standard arm with a tolerable safety profile. The benefit was consistent across the most pre-specified group, though there was a high risk group. So there were very few deaths in acalabrutinib and combination arm. So it is very early to say that the death rates are very less in this arm compared to that of other arm. We require a much longer overall for a follow-up to know the complete overall survival. So the second study is acalabrutinib in a relapsed CLL patients. The ASCENT study was the study which very important study of this drug. It did look into treatment of relapsed and refractory CLL patients. The number of patients studied were 310. Most of the patients had received either more than 2 or 3 lines of chemotherapy. There were also patients who received more than 4 lines of prior therapies. It had 2 arms. One arm was acalabrutinib single agent, which was given in dose of 100 mg BD. The other arm was rituximab in combination with idelalisib or with bendamustine. The treatment was left to treating physicians, whichever the regime which they can choose among the two. So there was, if there is any progression in the control arm, it was allowed to cross over to acalabrutinib arm. Primary endpoint were progression-free survival. Secondary endpoint were overall response rate, overall survival, and safety data. The patient, characteristic-wise, all 3 groups are very well matched. There were about 10% of the people who received more than 4 lines of therapy. As I was telling, majority of the patients did receive either 2 or 3 lines of therapy before. Most of the patients received purine analogs or the CD20 monoclonal antibodies in combination with bendamustine or other alkylators. So there were also patients who had, unmutated immunoglobulin AV status, which was about 70% or more. There were deletion 17p high-risk patients are also included, which were equally distributed in the 3 arms. So after 18 months of estimated progression-free survival, the acalabrutinib arm showed about 82% compared to that of the control arm of about 48%, which was statistically significant. Did show that the progression-free survival was much better for acalabrutinib compared to that of the control arm. The benefit was, as we have seen in the previous study, was across all the group, whether the patient carried T53 mutation, unmutated immunoglobulin AV change status, whether they had complex karyotype, the number of chemotherapies treated, bulky disease present or not. So across all the group, acalabrutinib did benefit compared to that of the control treatment arm. The overall survival, as there was no much difference after the follow-up of 18 months. This is majorly because about 25% of the patient in control arm were allowed to cross over to acalabrutinib. That may be the reason why we are not seeing so much difference, but still we have got to follow it up for longer time to see that there is any difference in overall survival or not. The duration of response, acalabrutinib arm about 18 months had about 85%, 85.4% of people responding compared to that of the control arm, which showed about 49%, which was statistically significant. About the patient disposition and exposure, as you can see that the duration of exposure in acalabrutinib arm was about 21.9 months, which was much lesser in the other two arms. The dose intensity was maintained in almost all the patients in acalabrutinib arm, which was lesser in the other two arms. The major discontinuation happened in idelalisib arm compared to that of the acalabrutinib. The major cause for the discontinuation of the adverse events. So the discontinuation in acalabrutinib was lesser compared to that of the idelalisib arm. The Richter transformation was seen in about 3% of the patients in both the arm, which was not statistically much more difference. The most common side effects that we see in the previous study were headache, neutropenia, diarrhea, and nausea. Of course, there were about 20% of the patient did have some sort of the respiratory infections, or the other infections were there. There was also, some patients reported anemia. The side effects, particularly like in previous study, were more important of atrial fibrillation, hemorrhage, infection, hypertension, and also the secondary malignancies. These are some of the side effects, though very less in number. We need to be looked for when patient is receiving this drug, because these patients are very frail and elderly patients. So these side effects were to be particularly looked when you start a patient on acalabrutinib treatment. So the summary, though the final results are awaited, with interim analysis, we did see that acalabrutinib had a better safety profile and efficacy. It did prolong the progression-free survival compared to that of the control arm after a median follow-up of almost about 18 to 22 months. The adverse events majorly were headache, neutropenia, diarrhea, but there were not so much, grade 3 or grade 4, which could be managed. The discontinuation rate of the drug was much less in acalabrutinib arm compared to that of the other arm, which had discontinuation were much more. So in summary of both the trials, acalabrutinib is a selective and more potent second generation BTK inhibitor. In both studies, whether it was used in naive patient or relapsed patient, it did show a better progression-free survival. And the benefit was seen in all the groups, whether they had high-risk cytogenetics or they had bulky disease or unmutated immunoglobulin heavy chain status. The side effects were there, but they were manageable, and discontinuation of the drug was much minimal compared to that of the other standard arm treatments. So thereby that acalabrutinib is now approved as a drug for both treatment naive and relapsed patients in a patient with CLL. Thank you.